disproportionately impacted.
Sorry,
worldwide, 81% of homicide victims were men and boys.
Yeah, sorry, we lost you for a second there. Just as you were starting your presentation, it went quiet. I wonder if you could just start again from you'd said you'd gone through the overview of your presentation, and I think just at that point we lost you as you were
absolutely
starting.
Yes, thank you. And please let me know if I cut out again.
Okay.
Thank you for letting me know that. A lot of the information I go over in the background, many of you know, so I apologize, but I hope it'll set the stage for the studies that I will be doing. So violence, as you all know, is a global health crisis where men and in many countries, young men are disproportionately impacted. Worldwide, 81% of homicide victims were men and boys in 2017. And although women experience less overall homicide than men, they experience the greatest burden of intimate partner homicide. Of all homicides committed by intimate partners, women were the victims in 82% of them worldwide in 2017. The diagram to the right comes from the WHO's 2002 World Report on Violence and Health, and it helps us to understand the context in which interpersonal violence occurs. For the WHO definition, interpersonal violence refers to violence between people and is subdivided into family and intimate partner violence and community violence. Family and intimate partner violence includes child maltreatment, intimate partner violence, and elder abuse, and community violence includes acquaintance and stranger violence. The diagram further divides interpersonal violence into 4 ways in which violence can be inflicted: physical, sexual, psychological, and deprivation or neglect. And for this study, we focus on physical violence. So violence is a recurrent problem. Experiencing a prior violent injury increases the risk for repeat violent injury and homicide. In US studies, up to 41% of violent injured people were reassaulted within 5 years. And one study led by Dr. Rebecca Cunningham at University of Michigan found that among substance using youth who were 14 to 24 years old that presented to an urban emergency department, those who were violent injured at the index visit were almost twice as likely to return to the emergency department with a repeat violent injury within 2 years compared to those who did not have a violent injury at the index visit. And then also there's a recent study looking at youth in Kailicha by Dr. Sarah Lieber and colleagues, and they found that 14% of violent injured youth in Kailicha returned with a repeat violent injury within 15 months. And they also found that almost 50% of the violent injured youth were injured from a fight in the past 6 months. So homicide is a good indicator of interpersonal violence. We know non-fatal violent injuries far outnumber homicides. One US estimate is there are 100 non-fatal violent injuries to each homicide, but there's less complete data on non-fatal violent injuries, so I'll just present homicide data here. And as you can see, compared to the US, most injury-related deaths in South Africa are due to violence. The homicide rate in South Africa is almost 4.5 times greater than the homicide rate in the United States. And the leading mechanism of homicide also differs between the 2 countries. The majority of homicides in South Africa are done by sharp force or stabbing, but firearm-related homicides are not too far off, and there's evidence to suggest that the burden of firearm-related homicide is increasing in South Africa. And as you can see, firearms are overwhelmingly the leading mechanism of homicide in the United States. South Africa and the United States have similar patterns of gender, age, and racial disparities in violence. In both countries, homicide rates are greater in men than women. Young people, specifically young men, are disproportionately affected. For instance, in the United States, homicide has been the leading cause of death for Black men who are 20 to 29 years old for over a decade. And Black people are far more likely to die from homicide than whites in both countries. And in the United States, that racial gap continues to widen. In 2009, Blacks were 5 times more likely than whites to die from homicide, and in 2020, they're 7 times more likely. And the racial and gender disparities we see in violence do not occur by chance. They're rooted in structural and social inequities. Structural and social determinants of health shape the racial and gender inequities we see in violence and many other health outcomes. So based on a framework by Dr. Joya Creer-Perry and colleagues, I'm going to frame the structural determinants as upstream root causes of social determinants of health. They include policies, institutional practices, cultural norms, and colonial legacies. And policies and practices that result in racial inequities are derived from structural racism. Structural racism is a macro level system, social forces, institutions, ideologies, and processes that interact with one another to generate and reinforce inequities among racial and ethnic groups. Examples of policies and practices that come from structural racism are Jim Crow segregation in the US and apartheid in South Africa. And the structural determinants set the context for the social determinants. The WHO defines social determinants of health as non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. Social determinants of health include poverty, unemployment and job security, income inequality, inadequate housing, food insecurity, low educational attainment, lack of public transportation, exposure to violence, and work conditions. And according to the WHO, structural and social determinants of health are more important than healthcare and lifestyle choices influencing health. So studies suggest that social determinants of health account for 30 to 55% of health outcomes. So here's an illustration of how the legacy of racist policy persists in a city like Baltimore, Maryland in the US. Right here is a picture of the Baltimore Homeowners Loan Corporation map created in 1937. Neighborhoods were graded by color, with red indicating neighbors with undesirable racial concentrations, which meant Black people lived there, and they were deemed to be the highest risk for mortgage lenders. Prior to the creation of this map, Baltimore was also the first city to create a policy that enforced racial residential segregation. Much of this residential segregation persists to this day. This map almost completely aligns with current neighborhood poverty rates, which you can see here. And then to the right, that map from 1937 also almost completely aligns with the map of homicides, which is right here from 2018. And it also matches many other health and socioeconomic outcomes not shown here. For instance, people living in the historically red areas have a lower life expectancy than people in the green areas. In an analysis from 2005 to 2009, people living in the census tract with the highest life expectancy lived an average of 30 years longer than people living in the census tract with the lowest life expectancy. And these areas are only a few miles away from each other. So redlining left Black families out of the mortgage market and vulnerable to predatory lenders. And this left Black families with no other choice than to reside in under-resourced, impoverished communities. So moving on to alcohol and drug use, there's a strong association between high levels of violence exposure and alcohol and drug use. Alcohol use is strongly associated with using violence and experiencing violence. In South Africa, violence-related hospital visits and homicides are highly associated with alcohol use. Abrams and colleagues found that women in South Africa who consume alcohol are at higher risk of experiencing intimate partner violence, and men who use alcohol are more likely to use violence against an intimate partner than men who do not drink. And then there is less data on illicit drugs such as methamphetamine, cocaine, cannabis, heroin, and violent injury. Illicit drugs are commonly detected in homicide victims. And the type of drug detected may vary by country. So for instance, methaqualone, or otherwise known as mandrax or mandrakes, is commonly seen in South Africa, but not in the US, and cocaine is more common in the US. And amphetamines and cannabis are common in both countries. Early life adverse experiences, low socioeconomic status and poverty, and comorbid mental illness increase the severity of substance use. And drugs and alcohol are found to overlap with all forms of violence at multiple ecological levels. The proportion of heavy episodic drinking and liters of alcohol per capita among people who drink is higher in South Africa than the US, but heavy alcohol use and dependence is a significant problem in both countries. There's a greater proportion of illicit drug use in the US compared to South Africa. However, the data here in South Africa, they're looking at past 3-month drug use compared to the US, where they're looking at past year illicit drug use. So they're measured differently. And then alcohol is present in a large proportion of homicide victims in both South Africa and the US. However, the proportions are higher in South Africa. So gaps in the research that help to influence the study is the current research focuses on individual level risk factors. There's less focus on societal and community level factors. Relationship between drug use and violence is less understood than alcohol use and violence. So marijuana is less associated with violence. However, there's mixed results in the current research. Methamphetamines and cocaine have stronger associations with violence. And many studies have combined drug types into one category, so they'll call it illegal drug use or illicit drug use, making it difficult to discern if certain drug types are more strongly associated with violence than others. There's a limited examination of mechanisms by which risk factors influence violent injuries, and limited description of in-depth experiences of drug-using people who have repeat violent injuries. So basically limited examination of the pathways leading to and context around recurrent violent injury, and limited studies using longitudinal data. So the purpose of this study is to further understand patient, including drug and alcohol use and comorbid diagnoses, neighborhood and injury-related factors associated with recurrent assault-related injury among adults age 18 to 34. This is a conceptual framework that's guiding these studies. So it's an adaptation of the integrated biopsychosocial alcohol aggression relationship framework by Shermack and Giancola. And the framework was developed to explain risk factors associated with alcohol-related use of violence. However, research suggests that the framework is also relevant to drug alcohol-related experiences of violence. And many people who have experienced assault-related injuries have also used aggression or violence in their lives, which I think further supports the relevance of this framework. And in the adapted framework, the developmental influences represent factors that are distally related to the risk of alcohol and drug-related violence, such as childhood trauma. The developmental influences interact with the proximal constructs of alcohol and drug influences, psychological influences like mental health, and contextual influences like setting of the injury, neighborhood disorder, socioeconomic status, neighborhood drug and alcohol availability, racism and masculinity norms. And these constructs are more proximally related to the risk of alcohol and drug-related violence. And the proximal domains, they have bidirectional interactions with each other. In recurrent assault-related injury, the outcome also represents a bidirectional relationship with the proximal domains. And another reason why I like this framework is because it emphasizes modifiable risk factors rather than non-modifiable risk factors. So this is a study design for my dissertation study. I'll quickly go through this study design and the aims for my dissertation study, but I won't go through all the methods for each aim because I'll focus the rest of this presentation on my Fulbright project, which is very similar to the qualitative phase of my dissertation study. So I hope I don't make this confusing. So the study design of my dissertation study is a convergent mixed methods design, where the quantitative and qualitative data are independently collected, and then the data is analyzed separately, then compared and interpreted. And then just quickly going through the aims of my dissertation. Aim 1 is my quantitative aim. I'll be doing a risk factor analysis using electronic health record and trauma registry data. And the aim is to examine if patient, neighborhood, and injury-related factors at the time of presentation to the hospital for a blunt force cutting, piercing, or firearm assault-related injury are predictive of recurrent assault-related injury. Aim 2 of my dissertation is my qualitative aim, and that is to describe experiences with violence and drug alcohol use in individuals who have experienced a past year repeat assault-related injury and had a positive toxicology screen at the time of injury or report current drug or alcohol use. And then aim 3 of my dissertation study is my mixed aim. It's to describe how the themes surrounding violence and drug alcohol use revealed in my qualitative aim further explain and extend the identified risk factors in my quantitative aim. All right, so now focusing on my Cape Town project. This aim is the same as the qualitative aim for my dissertation study, and it closely aligns with my Baltimore-based dissertation study. My plan is to compare and contrast the findings to gain a deeper understanding of the pathways leading to and context around recurrent violent injury. And this project will be conducted at, and I apologize for my pronunciation, Hruteskir Hospital. I'll call it GSH going forward. And at this hospital, studies have reported that the use of drugs and/or alcohol are among 28 to 30% of all their trauma patients, and blunt force, cutting, piercing, and firearm violent injuries are the most common injury mechanisms seen at GSH's trauma center. So the inclusion-exclusion criteria. Inclusion criteria are men and women 18 to 34 years old who experienced a past year repeat blunt force, cutting, piercing, or firearm assault-related injury, and had a positive serum or urine toxicology screen for drugs and/or alcohol, or they report current alcohol and/or drug use, and they speak English, isiXhosa, or Afrikaans. Exclusion criteria are if they lack the capacity to consent or are in custody of the police or are prisoners. Sampling, I'll use purposive sampling, and we'll plan to recruit at least 30 participants. Data will be analyzed until data saturation occurs. Injury type will drive the analysis. So I will try to get a mix of individuals per injury type and also an equal number of men and women. Eligible participants will be identified through hospital charts or referred by providers, and they must be stabilized within 72 hours of admission, and treatment will never be interrupted. For data collection, I'll be doing in-depth, semi-structured individual interviews. They'll be face-to-face. I don't have this on the slide, but an interpreter will be present for all interviews, even if they are conducted in English. And the reason for that is I think so I'm an outsider. I think someone that's more familiar with the culture of the patients will be better able to identify any nonverbal cues that I might not see or that I may misinterpret. So I plan to work very closely with interpreters and will I hope that it'll be a very collaborative relationship between myself and the interpreters when doing this project. Participants will be asked to describe experiences related to their initial assault-related injury and subsequent assault-related injuries, and to describe patterns of drug alcohol use at the times of injury, prior to their injuries, and after their injuries. And the interviews will be audio taped and transcribed verbatim. So the questions that I ask will be around the 3 mechanisms in the framework. So for psychological influences, I will ask questions around psychological symptoms, alcohol and drug use, any addiction healthcare experiences, and individual resilience. For contextual influences, there will be questions surrounding setting of the injury, neighborhood violence, or community violence, community drug and alcohol availability, racism and masculinity norms. And for developmental influences, there will be questions around family composition and family support, childhood trauma, parental substance abuse, and parental violence. For the data analysis plan, I'll use a qualitative descriptive approach with content analysis. And this approach is less interpretive, focusing on meanings and intentions while considering the context or environment. Data analysis will occur continuously, starting at the data collection phase. I'll use inductive open coding. The codes will be organized into a code book, and then categories and themes will be identified, and I'll be using written memos. And then the definition of data saturation that I'll be using is that it will occur when 3 consecutive interviews are conducted with no new themes across or within each domain. And if there's no data saturation within 30 interviews, then the stopping criterion will be tested after each successive interview. So limitations and strengths, these are the limitations and strengths of my entire dissertation study and this study, but the main ones I think for this study, and there's actually probably many more, but recruitment challenges. I had a lot of recruitment challenges in Baltimore, or still am, and I anticipate that there will be recruitment challenges here as well. Also, cross-language interpretation. I have no experience with cross-language interpretation, and what that means is the interpreter must navigate receiving data in the source language, and then conceptualize and understand the meaning of that data, then re-express the meaning within the cultural context of the target language. So I anticipate there may be challenges with that, but I'm hoping actually that maybe that will be more of a strength, because I'm hoping to have a collaborative relationship with the interpreters, because inherently the interpreter will shape the qualitative research outcome. So I'm hoping this will actually be more helpful. And then implications. So I hope that this study will, or both of these studies, will further the understanding of the complex relationships and intersections among multi-level risk factors, especially drug and alcohol use and repeat violent injury. This also may lead to a revision and application of the conceptual framework guiding the study, and I hope it will inform hospital-based violence intervention programs and treatment for substance disorders among assault-injured adults. And then for future research, I hope to have a collaborative program of research between South Africa and the US, where we can work together to identify how complex risk factors, including substance use, work together to increase the risk for repeat violent injury. I hope to further understand effects of structural and social determinants on intersections of violence, substance use, and mental health, to identify effective treatment interventions and address barriers to care among vulnerable populations, and then later on to develop and evaluate hospital and community interventions that are focused on reducing interpersonal violence and treating substance use. And then I'm just ending with this quote from Kuvadis and colleagues with the importance of addressing structural and social determinants So they say programs that directly address social determinants of health and development, such as discrimination and stigma, subordination of women, poverty and inequality, violence and traditional practices, are essential for promoting health and reducing disease. And then I just want to thank Professor Matsopoulos for hosting me and being my Fulbright advisor. And I can't believe I didn't add his name here, which is horrible, but Professor Pradeep Navsaria, which I've been working very closely with at GSH, and then my dissertation committee and just acknowledging funding. And that's everything, and references. So I will stop sharing. And I will turn my camera on. So if anyone has any questions or comments, or suggestions.
Apologies, I think I was on mute there, but just to say thanks very much. It was very, very clear and thorough and thought-provoking presentation. It would be great to open the floor for questions and discussion. And if you could raise your hands, it would probably be the easiest way to orientate us if there are inputs from the floor. When you do speak, could I ask you just briefly to introduce yourself as well, which will help Lea with orientation as well, to know who you are, and me too, perhaps. But maybe I could start the discussion by asking you a question, Lea, while we wait for the others to collect their thoughts. Your presentation is talking about the association of substance abuse or alcohol and violence. But one of the key things is you're looking at repeat victimization, and I was just wondering if you could opine on the risks associated with alcohol and drug use as, you know, and the risks that they pose to the user to increase aggressive behavior. So for the perpetrators rather than the victims that end up in the trauma units. That's also a very pertinent question, I would think. You know, what is the root to violence from substance abuse? Is it just a case of increasing the risk of victimization so that people under the influence are the preferred victims for perpetrators, or is there another dimension as well in terms of increasing risk for aggressive behavior?
I am so sorry. I don't know if you can hear me. My connection is not good, and I didn't hear anything you just said. I'm so sorry.
Yeah, turn off the video. Maybe turn off the video, Lea. You did freeze there for a second.
Yes, I turned my camera off, but there seems to be a lag because I can see my picture still on your screen, but my camera is off. Can you repeat the question? I apologize.
Yeah, sure. It was, others might have heard the question, so I won't repeat it at length because it's a bit of a long-winded one, but I wanted to ask about the relationship between alcohol and substance use as a risk factor, not only for victimization, because essentially your study is measuring the association with being a victim of violence and substance or alcohol use, but also amongst perpetrators, predisposing the perpetrators to increased risk of violent or aggressive behavior. I'd expect that it's also involved in that relationship, and I was wondering if you could just opine on that and explain if we should also be considering that association.
Yeah, yes, absolutely. I think there's a lot of literature, I think, looking at alcohol use and the perpetrators or people who use violence, a strong association between that. And also, I think there's evidence also to show there's association between drug use and people who use violence. And I think that's a very important consideration, especially if we focus on the people who are experiencing violence. We don't want to blame them for being assaulted, to say like that because they use substances, that's the reason why. So I think it's also important to be sensitive to that. But I do think we need to consider substance use among people who use violence. Not sure if that answered your question. And also, I guess it's also a cyclical relationship too. So a lot of people who experience violence also use violence as well. So that also makes it complicated. But I'm not sure if that answered.
It does in part. I think the reflections I've heard from trauma surgeons in particular is that amongst the repeat patients that visit semi-regularly, they're sometimes visiting as patients and sometimes as visitors of other patients. In other words, it's a bit of a lottery during a substance use event if they're under the influence as to whether they're going to end up as the victim or the perpetrator in that incident. But it's probably a useful consideration when you conduct the interviews as well, maybe to try and unpack some of that context.
Thank you. Yes, I agree. Thank you so much.
I was fascinated by the structural elements in your presentation comparing Baltimore to South Africa generally, and certainly what you've spoken about in terms of the land use planning and the structural dimensions of poverty, I'm sure you will have encountered here as well. Is that something that is unique to Baltimore, or are there other cities in the US that are similarly separated? It's a new aspect to me. I wasn't entirely familiar with it, so it'd be good to look for that in future.
Yes, thank you so much for that question. It is not unique to Baltimore. You can see it throughout many cities throughout the entire US. And it's a result of lots of different policies. But the big one, the example I shared with the redlining and the homeowners loan corporation maps, that was throughout the United States. So the example I gave with Baltimore, you can find those maps in many other cities, and those maps map on to the racial disparities you see in those cities as well, like the current day racial disparities you see in the cities as well. And that's just one policy. I mean, other ones are the Jim Crow segregation laws in the South, and the GI Bill. So allowing people who came back from World War, or who served in World War II, were allowed to go to college. Either it was free or of little cost. I can't remember, but that was not afforded to Blacks. So whites basically were the only ones who were advantaged by that. And then there's several other policies.
Fascinating. Thanks very much. Last question from my side, and it's, I'm asking you to do some crystal ball gazing to an extent, but I'm sure you've been grappling with some of these questions as you progress through your PhD research program. And it's quite self-serving, because I think when I do the lecture for the medical students, I try and explain how important it is for them to be involved in this area of research. It's something, violence research is not something that features very prominently in the curriculum. And to try and bring it home to some kind of practical, a kind of a practical lesson to take from the lecture, I look at three things. The first is trying to find a way to integrate prevention activities within a trauma care setting, so that there's some kind of referral pattern for the patients that they see. I think that's something that's very much lacking in the South African environment. I was wondering if you had an opinion on that. The second thing is the importance of the data that comes from the health system for advocacy purposes. It's difficult to trust the information that's released by the police, for example, but from a healthcare setting, it's very often a much more trustworthy source. So to encourage them to be active in data collection for the purposes of advocacy. And the final area, and one where I wanted to get your opinion, for repeat trauma, what opportunities are there for prevention? What programs could we put in place, and are there opportunities in a trauma care setting where we could intervene, refer, or try to direct patients so that they're at reduced risk? I realize it's kind of the purpose of your research going forward, but I was wondering if you had any thoughts at this stage that you could share with us.
Yes, thank you for that question. I'm still learning about interventions that are evidence-based that help to prevent repeat violence among people who present to hospitals and trauma centers. I know in the United States they have these hospital-based violence intervention programs, but they're not implemented in a consistent manner, and they can vary a lot from each other. So the data around them has been mixed, and there's not a lot of very good studies, high quality studies that have been done. I know in the trauma center I work in, typically they have social workers, and they have like peer mentors, so people who have experienced violent injury, who have been able to benefit from resources that were provided, and so they were able to continue with school and then become these mentors. They work with violent injured patients, and they help to connect them with community resources around employment, housing. A lot of our patients in Baltimore have inadequate housing, and they help with education if that's something they want. A lot of help with criminal justice matters, things like that. You know, they may help, but I don't think we really know what works. And again, I'm not sure if that answered your question.
It does indeed, yeah. Thank you. It gives us something to go on as well, and I think it emphasizes the need for the research that you're conducting. So I think we look forward to hearing the results and what your findings are, and hopefully your research will add to the evidence base eventually. I see a hand from Muzamil. Muzamil, I'm going to hand over to you if you could just introduce yourself briefly. Thank you.
Thanks, Richard. So Muzamil Islam, I'm a public health registrar in the school. Thanks, Lea. I mean, really just an excellent presentation, and I'm certainly looking forward to the results that come out of the research. Just on that last point, I definitely agree that there's a need for evidence-based interventions, particularly to prevent recurrence. There's almost an opportunity that's emerging between the first presentation or the index presentation, and the question is, from that time to 15 months or 2 years thereafter, what is the thing that works that can actually reduce that number? My question really is around you mentioned that one of the gaps in the research relates to the subtypes of drugs and the association with violence. And I noted in your qualitative component, you mentioned that you'll be looking into alcohol and drug use. And perhaps just to ask, like, what kind of depth will you be looking at in terms of the granularity of substance use in that target population? And then secondly, how do you foresee that pattern and the type of use comparing with recurrent assault-related injuries?
Thank you so much, Muzamil. It's such a good question. I think the quantitative phase of my dissertation study more is getting at the specific drug types, because the trauma centers that I'll be looking at in Baltimore, they are pretty good at collecting toxicology screens on every patient that comes in. So I'm hoping to be able to get the granularity there. For the qualitative interviews, I will be asking about the specific drug types that they use. I'm not so sure if, I don't know if that will help us to see as much the specific types and the relationship between specific types and recurrent injury as much as the quantitative data will, but I'm hoping maybe it will give us a little bit of context around certain types and maybe how that might increase risk. And I apologize, what was the second part of the question?
No, thanks. I think you've covered it. So that's really it. Yes, about subtypes, but that covers it. Thanks so much for that answer, Lea.
Thank you, Muzamil.
Thank you. I see two hands went up in quick succession, but I think, Alex, you were just first. If you could just introduce yourself, please, and go ahead.
Absolutely. Thank you so much. So I'm Alex DeBow. I'm a senior lecturer in the Division of Epi and Biostats. So thank you, Lea. This is a fantastic presentation. I had more of sort of a practical question just around how you were going to go about identifying people that are, sort of being hospitalized for a recurrent injury. That's going to be done through sort of self-reports or through assistance from kind of medical records. And then is recurrent defined as sort of the second time that an individual is hospitalized for assault, or not necessarily, or an assault that might not have led to hospitalization in that setting? Thank you.
Hi, Alex. Thank you so much for your question. Yes, so determining whether it's a recurrent assault will be based on self-report and looking through the hospital chart. I'll only be able to determine it through the chart is if the only way I can determine it through the chart is obviously if they presented to GSH for the prior injury. So I will be relying on self-report. And my definition for repeat injury will be where they had to seek medical care for that injury. So yes. Did that answer both your questions?
Yes, absolutely. Because I think, you might, just in terms of missing or the sensitivity of that, if you were only relying on medical records, I think that's great. And then just one other comment is just around, I'm sure, in situations with intimate partner violence and partners sort of maybe even being in the hospital at the time, if you thought around sort of, the interview process and how things will look like. Thank you. That's it from me.
Thank you. That's a really good point. So yes, I think, thank you for that suggestion. We can definitely just rely on the medical record. And right now I'm actually working on a separate unrelated project, going through medical records. And I'd have to say the majority of the patients that had come in for an assault, it is either their second or more. They've either been at GSH for one or more prior assault-related injuries. So we can definitely do that. And then as far as having a partner present, that's a really good comment. My plan is to not have anyone present when we do the interviews. So it will just be me, the interpreter, and the patient. And if there's anyone visiting, we'll ask for privacy. Unless a patient, well, actually, I think that that will be what we do. I don't really see many instances where we would reconsider that, just to make it equal throughout the process for everyone.
Okay. Super, thank you. And Jessica, your question, please. You could just.
Hi, thank you so much. I'm Jessica. I'm a public health medicine registrar working at UCT in the division. Thanks so much for your talk. I'm also fascinated by your comparisons between South Africa and the United States. I think we tend to think of ourselves as very different, and it's interesting to see the similarities in many of the structural determinants of health. You've spoken quite a bit about socioeconomic statuses and social determinants of health, and I'm not very familiar with the US system, but from what I understand, it's very private health insurance based, with some covered for emergency care for those who don't have insurance or are on the sort of government package, if I can call it that, which I'm sure is incorrect. I was just interested in the support package that you mentioned, where someone would maybe get social work support after they have received their emergency care, and wondering whether this is the kind of thing that someone would have to pay for out of pocket if they didn't have insurance, and how can you, I'm just curious about your experience in the US with people who might be socially economically vulnerable and not necessarily be able to afford healthcare, but then wanting to provide them with additional support like psychologists or psychiatrists or social workers that they may or may not be able to afford. So I'm not sure whether you can comment at all on that, just to get some insight into the context. Thank you so much.
Jessica, thank you for that question. Yes, so in the US, we have private payer, public payer, which is predominantly people who are socioeconomically disadvantaged typically have public payer insurance, and then people who are uninsured. Our insurance system is complicated because it also depends on the state you live in. So some states have more access to public payer insurance than others. Maryland, which is where I live, has pretty good public payer insurance. So there's very few patients we have that are uninsured. And again, that varies by state. In states that have very restrictive public payer access to insurance, there's many more uninsured people. So in Maryland, there's very few patients we have that are uninsured. However, many of them are underinsured. So like you said, and you were exactly right, they don't have the adequate access to mental health care. So the social work services that they will get because they present it to the hospital regardless of their insurance coverage. However, what they have access to in the community does depend on their insurance status. And so since a lot of people are underinsured, they rely a lot on sort of community-based programs that offer mental health services to people with public payer insurance. And mental health is a particular struggle because there's a shortage of mental health providers in America overall, and even less who provide care to people that have public payer insurance. So the social workers have to rely a lot on sort of community-based organizations that were created specifically to help vulnerable people, but oftentimes these organizations are overstretched, so it does make it difficult to be able to provide people with the needs they have. And then also, I think it's also challenging because when they come to the hospital, you know, we're great at treating their physical injuries, and even though we connect them to social work and try to connect them to community resources, they're still going out to the same communities that have the same problems. So that's why it's so important to address the structural issues, because even if you address some of the social issues, you know, it's only gonna help so much. I hope that was long-winded. I apologize.
Thanks so much. No, that was very interesting. Thank you.
Okay, thanks very much, Leslie. We've got a question from the floor. Would you like to?
Lee, I think you can hear me quite.
Yes, I can hear you. Yes.
So thanks very much. A great presentation. So two things. One is because you are focused on individuals, users of the health service, I wonder the extent to which you can really get to the sort of upstream factors through that data collection. So I'm thinking, for instance, in many of the patients who arrive at critical care will have come from communities where the marketing of alcohol is absolutely rampant and very well resourced. alcohol industry is very good at advertising, very good at marketing. Those trucks barrel into Khayelitsha every Friday to deliver tons of alcohol to shebeens that will distribute them. Yet those same companies are presenting themselves as helping to solve the problem by education. So I wonder if your research is at all going to be able to grasp that, because you're interviewing the person who's the victim, either of either being a victim or being a perpetrator. And then sort of related to that, I wonder if any of your work would look at questions of kind of community social capital and community resilience, because it strikes me that solving the problem one person at a time is a lot of effort, and maybe you might find a small measure of effect that's significant, but the thing that will change for a lot of people will be strengthening communities to be less vulnerable to the impacts of alcohol. So maybe it's not possible in your project, but I'm just raising it for what you think.
Hi, Professor London. Thank you so much. Those are really very excellent points. And I think we might be able to address them more in the qualitative interviews. As far as context, I only ask questions around neighborhood drug and alcohol availability. But I mean, you bring up such a good point about the advertising, and just the I guess the disproportionate presence of these alcohol outlets in these really vulnerable communities. So I think I should think a lot more about how I can look at that sort of context. I'm probably just looking at it at a very superficial level with the interviews. And then, sorry, community resilience. Yes, that's very important. Again, I just have some kind of superficial level questions about neighborhood and how comfortable they are around their community members, and if they feel the community is, how tight knit they feel the community is. But again, I don't think I could probably work and think a lot more about how we can get at that as well. And I think more of the questions are around individual resilience, but you're absolutely right around how important community resilience is. So yes, thank you. That gives me some important things to think about and that I need to consider.
Yeah, I'll send you some. So there has been a little bit of work around that, so I'll send you whatever has been published on that or researched on that.
Thank you so much. I'd really appreciate that.
One of the difficulties, I think, is the study site in the catchment area for Grooteskill. So we've got some of those metrics from our work in Khayelitsha, but of course, Khayelitsha doesn't go to, those cases end up at Tygerberg Hospital. So sorry, yeah, I was almost able to save the day there to an extent, but unfortunately not. But I'm sure there's information that you could tap in for the Grooteskill catchment areas as well. I don't see any more hands. Any last minute thoughts or comments? Otherwise, I think we can bring the meeting to a close, and to thank Lea very much for her presentation and for fielding quite a range of questions, which I hope has helped shape the work going forward. And thank you for illuminating some of the aspects of your project and in this field that we weren't familiar with. So thank you, Lea. Thank you all for your attendance, and I'll bring this meeting to a close. See you again at the next new meeting. Thanks very much.
Thank you so much. I really appreciate everyone's time.
And of course, we've all seen The Wire.
Yeah, we've all seen The Wire.
Yes. Yes.
I think
we're educated about Baltimore through The Wire.
Cape Town should possibly be the site for the next series. Thanks very much, everyone. Take care. Bye-bye.